Very good evening to all of you in the fourth NSSA webinar series. I'm Dr. Jay Sardara, convener of the NSSA webinars. On behalf of NSSA committees, would like to warm welcome to all of you. So infective spondylodiscitis, it's not only the challenging and complex and debatable problem, but it's very important to discuss because it is one of the common spine problem which complex and we are day to day itching with it. How long anti-infective agent should be given? What kind of anti-infective would be effective in my patients? When to do surgery, when not to do it, whether keep the instruments or remove it, and what kind of instrumentation strategy should be decisive and applied. With all the debatable issues, we have very, very famous national faculties with us, very experienced faculties with us, which will discuss with us today these issues. I would like to welcome Professor Ramani sir, our NSSA founder. Welcome sir, Professor Kale sir, SS Kale sir is the head of department of Sri Chitra Institute, AIMS Delhi Institutes. Professor Krishna Kumar sir, head of department and professor at Sri Chitra Institutes. Welcome sir. I would also like to welcome Dr. Deepak Bangle, minimal invasive spine surgeon, very famous in Delhi. Welcome Deepak. I would like to also welcome Dr. Kirti Sabnis. She is a infective disease specialist, well known in Mumbai, practicing in Mumbai. Dr. Shukumar Sura, it's a well-known figure for endoscopic, full endoscopic interlaminar technique in India. And he will also discuss about his perspective. My dear friend, Dr. Apurva, very young and dynamic neurosurgeon in Mumbai as a moderator. So before we move ahead, Ramani sir, would you like to give us the blessing to go ahead?
Thank you, Dr. Ramani, and NSSA welcomes everybody, the participants and the listeners, for this very, very important fourth NSSA webinar on infection in the spine. I am old. Olden times, this was very, very frequent, very common. Many times.
It's 6 o'clock.
Hello?
Yes, sir.
Yes, sir.
Many times, we always thought it was tuberculosis because tuberculosis was very, very common. Similarly, in private hospitals, the aseptic precautions were not as good as in corporate hospitals, and therefore, whenever someone operated and got an infection, we knew it is directly inoculated infection. As time changed, things also changed. Somehow, spondylodiscitis became less common. Then the things like immunosuppressants came, HIV came. I have a feeling that many times when a person does not respond to standard treatment of AKT, we say it is a drug resistance TB. It may not be so sometimes because we standard give AKT4 or something like that, and for the volume, for the size of that patient, it may not be sufficient, and therefore he may be suffering from less sufficient drugs rather than drug resistance. And this is a point one we have to care carefully. It is a very, very challenging and yet not very commonly discussed chapter. And today's webinar is going to be extremely important, especially for learners, because it has very, very valid points to be discussed into it. And I sincerely hope everyone enjoys this today's seminar, learn it, and maybe perhaps we can take this issue, Apurva Prasad, to make a print out of it and distribute to the NSSA delegates because this is such a very, very important subject that we are discussing today. Thank you very much. Thank you.
Yeah, Apurva?
Yeah, thank you, sir. I welcome everyone once again to this webinar. Just two announcements I would like to make. One is, as is the protocol of Professor Ramani and NSSA, I request all the speakers to please stick to their time so that every speaker gets the same amount of time to present their talk. And the second thing is, we have lectures for 10 plus 2 minutes. So we will have all the lectures together, and then we'll have the discussion on all the lectures just before the panel discussion. So with that, I request Dr. Ramani and Dr. Kale sir to please start the session and invite the speakers.
Dr. Kale, please.
Yeah. Good evening, and welcome everybody to this very important webinar. As pointed out by Professor Ramani, there are a lot of things to learn over here. And the scope of this webinar is big because as Dr. Jayesh has pointed out, some of us are going to speak on tuberculosis, which is a big problem in India by itself. And there will also be some part dedicated to non-tuberculous infections of the spine. And how to diagnose it, how to treat it, what kind of surgery to do, what kind of implants to use, how to approach the spine or how to approach the site of the infection. Should we go anterior? Should we go posterior? Should we go combined? When to do conservative? When to operate? All these questions, I hope at least some of them will be addressed by our speakers in the panel here today. So,
Yeah.
Jayesh, with this, I invite the first speaker to go ahead and present.
Yeah, Apurva?
Yes, sir.
Yeah, please start the session.
I request Dr. Deepak Bangale to please start with his lecture.
I'm audible?
Yeah, you're audible. Please start.
Thank you, NSSA, and thank you, Professor Ramani. Thank you, Jayesh. Thank you, Professor Gali. And thank you, Apurva, for giving me opportunity for speaking on infective spondylodiscitis. So next 10 to 15 minutes, I'm talking about the overview of the infectious spondylodiscitis and what are the clinical differentiating features and radiological features we are going through. So greetings from the Medanta, the Medicity. So what is spine infection? That infection that involves more of the one or more spine structure like vertebra, called osteomyelitis, discitis, joints, arthritis. Sometimes the infection goes to subdural space, sometimes goes to epidural space. It's called the abscess, phlegmon, and sometimes it causes meningitis and sometimes myelitis. This whole spectrum is of more of infectious spondylodiscitis. Basically, it's an infection of the vertebral body or disc which involves epidural space, sometimes posterior elements, and paraspinal soft tissues. So there is a spectrum of abscess plus discitis plus spondylitis plus paraspinal infections. So infectious spondylodiscitis is account for 2 to 4% of the skeletal infection. For pyogenic is the most common organism is Staphylococcus aureus, and for non-pyogenic organisms from Mycobacterium tuberculosis, Brucella, fungi, and other parasites. Definitely, as per Dr. Ramani already said, that is a challenging for diagnosis to make. Because the back pain and neck pain is a very relevant, means very more common in Indian population for any reasons. So most of the patients are present with the back pain and neck pain are the common complaint. But routine radiograph for this purpose is very little help in the early stages of to diagnose the disease. Nonetheless, it is surprising that average delay in diagnosis of spondylodiscitis, it takes 2 to 4 months. At that time, the majority of the patient have the sometimes cord injury also happens because of this. And next symptom is the fever. Bear in mind, the fever is common but inconsistent feature, and it's present only in less than half of the patient with the pyogenic infection, and even less in fungal, mycobacterial, or sometimes the brucellar patient. So back pain of the typically of the patient have located seated their vertebral level, occasionally radiates to the extremity, very occasionally radiates to extremities. It is exacerbated by the physical activities, and patients tends to keep patients wake up at the night. It's called a night cries. and they complain that they cannot find a comfortable position in the bed. They are toiling in the bed here and there, and there is localized percussion tenderness also happens. So going for the pyogenic the spinal infection discussion, it is rare. It definitely delay in diagnosis happens, more common in males. More majority of the patient in the fifth decades, and younger also means less than children, and older also more affected. Microbiologically, pyogenic most common organisms Staph aureus. Second is Streptococcus pyogenes, E. coli, Klebsiella, and many more. For tuberculosis, we already know Mycobacterium tuberculosis. In fungal, there is Aspergillosis and Coccidioidomycosis. So, as a pyogenic discitis, gram-positive aerobic cocci is Streptococcus aureus 57%, gram-negative is E. coli, and anaerobic is Propionibacterium is most common. According to the site-like skin infection, Staphylococcus aureus is more common. In IV drug, it is Pseudomonas, but not in common in our countries. In Western countries, it is more common. In UTI, E. coli is more common. Genital-urinary infection, UTI is common. Respiratory and Streptococcus pneumoniae is more common. So, risk factor for the pyogenic discitis is a previous spine surgery. As far as this is a separate topic, separate issue. Sometimes some immunocompromised condition like HIVs, oncological histories, renal failure, diabetes mellitus, and advanced age. These are the more risk factors for this. So what is the pathophysiology? What is the routine routes of infection spread? It goes by the hematogenous spread by via spinal artery. There's a Batson plexus called as prevertebral venous plexus that also causes the infection spread. There is a pathophysiology of thrombosis of metaphyseal artery, leads to needles to the infection. And these are the end plates, and the discs are the more or the risk factor for this. And this secondary septic thrombosis of pupital vein neural abscess, and this leads to the neural deficit. So two major theory, hematogenous dissemination are the venous theory, and one is the arterial theory. Venous theory put forward by the Batson, which showed that there is a pelvic retrograde flow from the pelvic venous plexus to the perivertebral venous plexus via valvulus meningoarterial veins. These are the cadaveric model studies, so suggest that there is a pathophysiology of the bacterial spondylosis. At the same time, for arterial route also, there are the infections starting from the bony cortex and going to the epidural space. They are the arterials, capillaries, and vertebral end plates where this infection is spread to the disc and surrounding structures. So first you start with the metaphysis, then the bacterium involved, then is again going into disc nutrition impeded, and this causes the disc infection, and then in last into the end plate destroyed and causes pain and instability. Venous route, this valvular veins already discussed with the retrograde flow and causes infection to surrounding structures. In children and adults, same fractures happen. In children, in septic embolism is unlikely to produce abscess infarct and infection limited to disc. But in adults, it goes into surrounding areas also. So pathophysiology already we discussed. So constitutional feature, back pain, neck pain already told. Back pain, neck pain, fever, malaise, neurological deficits are not specific. So what are the red flags? If the back pain of less than 15 years of age and for more than 55 years, thoracic back pain, night cries, and constant and progressive signs and symptoms, focal neurological deficit, we go for suggest there is a red flag and go for investigations. Again, now go to switch over to TB spondylodiscitis. So TB is a world major global burden of in India, at least in India. There are 10 million new cases of tuberculosis and 1.2 million people die of the disease every year. Among these who died, 250,000 have HIV positives. The Indian countries, majority of the 66% of starting from India to Bangladesh, South Africa. So out of this 4 lakh have multi-drug resistant tuberculosis. So and only 556% treatment success. So Mycobacterium tuberculosis have a bacillus with high lipid and proteoglycan rich cell walls. It's a slow growing aerobic organism, acetyl bacilli. In favorable condition, its doubling time is 20 hours. But in unfavorable condition, it grows intermittently as remain dormant for a prolonged period. That's why TB is difficult to diagnose because of dormant periods. The pathophysiology also same that sometimes it causes osteolysis because of destruction of tuberculous bacilli. Then is hamper the vascularity, leads to osteoporosis, then leads to osteonecrosis. All these three factors lead to collapse of disc space and vertebral body collapse. And this further leads to abscess, local kyphosis, and retropulsion of the bone. And then further leads to spinal cord compression, neurological deficits. So the collapse of the vertebral body and rarefaction of anterior aspect of vertebral body and forming the gibbous formation. These are the hallmark. So clinical feature of TB, you already know axial pain, constitutional symptoms, paravertebral abscess, kyphosis, knuckle, gibbous and guber kyphosis, and neurological deficits. So pain in tuberculosis is attributed to like a nagging pain. Is aching pain due to the abscess. Sometimes severe pain due to the instability. Sometimes the night cries because of exacerbation at the night and instability because of tripod sign. But radicular pain sometimes is uncommon in tuberculosis. Constitutional symptom is systemic disease, definitely have loss of appetite, malaise, weight loss, evening rise temperature, and more common in patients with of the malnutrition. Cold abscess seen in 30% of the patient. There is a paravertebral swelling, and sometimes the swelling goes to the abscess spread to the perineal, means perivascular, perineural, intermuscular, sometimes subpleural, and sometimes retropleural in directions also. It goes into superficial planes, typical feature of the cold abscess. If it involves the cold deeper abscess, then pressure symptoms on the neighboring structures can be affected. You should be treated early with 82 to resolve gradually. If left untreated, it leads to abscess and sinus formation. So don't to be drained to the cold abscess. So sometimes TB present at kyphosis. If anterior disease is called kyphosis inevitable. Single vertebral involvement causes knuckle deformity. 2 or 3 adjacent vertebra causes gibbous, and multiple adjacent vertebra causes rounded kyphosis. Neurological deficit, 30% of the cases it can present in acute and late stages also. So what are the main methods to diagnose these are infectious spondylolisthesis? Plain X-ray, CT scans, radionuclide bone scans, and MRIs. So X-ray is earliest change to occur 2 to 4 weeks. It's required 2 to 4 weeks to after the onset of the disease to see on the X-rays. The first radiological signs include discrete radiolucency localized within the subchondral region. And sometimes there is a loss of definition of end plates and narrowing of the intervertebral disc. So narrowing of the disc space is the most consistent radiological sign and noted in 74% of the patient at the presentation. And sometimes there is osteopenia with decreased density of the adjacent end plate. This is also frequently seen. Then suspect for the infection or something else. But radiological findings typically lag 2 to 3 months behind the clinical response. These also show with reactive to bone formation. There is sometimes there is sclerosis and loss of disc space. You can see there is sclerosis and persistently, and there is disc space loss, and but is a more of advanced stages findings. So there is no role of proper X-ray finding for early diagnosis. CT scan definitely better for detailed anatomy, but only in case of when there is bony destruction happens. If there is adjacent soft tissue mass or abscess is there. When there is abnormal, if you go for contrast, then there is abnormal disc space involvement, vertebral marrow involvement. It can enhance. Then CT scan helpful. Sometimes we can plan the biopsy according to CT scan. So CT scan also used for this. And sometimes there is a CV junction tuberculosis or CV junction discitis or Spondylodiscitis infection or SI joint pathology. CT scan definitely helps. Now comes the MRI. MRI is the highly sensitive and specific for this, and is currently the investigation of choice because its sensitivity, because of end plate enhancement, is the earliest sign of the acute spondylodiscitis. You can see definitely on the MRI. It can give a better idea for the sensitivity to diagnose this. This is a case of pyogenic spondylodiscitis. So what is the classical finding of MRI on clinical pyogenic spondylolisthesis? Is the detection of the fluid. If your disc shows there is a simple fluid like edema or abscess in the disc space, this is the early finding of the spondylodiscitis. Also, stir image, also there are discs with adjacent vertebrate involvement. There is a definitely early sign of spondylodiscitis. In advanced stages, definitely there is in-plate erosions, sometimes vertebral destruction, collapse, kyphosis, extensive abscess, and granulation tissue formation. And also, pyogenic involvement mostly occur at the lumbar level as compared to the tuberculosis. Tuberculosis is mostly of the thoracic and cervical level. It is more of lumbar level. There are 2 adjacent lumbar vertebra, and this so there is some fluid changes also you can see. T1 hypo and T2 hyper is a typical. An extradural extension of infection on the cord compresses the phlegmon and abscess. 2 adjacent vertebrae. The phlegmon and abscess, their difference. Phlegmon, you definitely have a complete wall. In abscess, you have ill-defined and ill-defined spread is an abscess. In advanced spondylodiscitis, you can say there is infection spreadily into the prevertebral tissues also. This is the advanced grade of pyogenic discitis. Then comes to tuberculosis. The tuberculosis, we have well-defined paraspinal collection, thin, smooth abscess wall, subligamentous spread to 3 to 4 more level vertebrae, multiple vertebral body involvement, entire body involvement, vertebral collapse, skip lesions, and large paraspinal cord abscess. These are the pathognomic findings on MRI of the tuberculosis. There is definitely a subligamentous spread is the most common in mostly involvement. Definitely, TB is a chronic, insidious, anterior spine and thoracic spine more involved relative preservation of the intervertebral disc. But majority of the time, advanced disc is involved. Sublingual. In pyogenic, there is definitely acute, rapid, lumbar motion involvement. Epidural involvement is there. Early involvement of disc is a lumbar fracture. There is a chart of showing that there is a difference between the pyogenic and tuberculosis. Definitely, the whole chart is there. So most important is there is a loss of cortical definition is absent in the pyogenic as compared to present in tuberculosis. Paraspinal enhancement well demarcated in tubercular compared to pyogenic. They're poorly demarcated. T2 hyper, it is there a T2 heterogeneous signal. Epidural abscess more common in tubercular as compared to this one. Abscess wall is thick and irregular in pyogenic, thin and smooth in tubercular abscess. Next comes to the types of paradisc. Sometimes there are 4 types of tuberculosis discitis, spondylodiscitis. One is paradiscal type, is the most common type. One is a predominant vertebral involvement called as centrum type. Posterior type is the posterior element involvement. A non-osseous type is bone restriction along with the cold abscess formation is the another 4 types of involvement. Sometimes there is a disc preserved in tuberculosis. Is all, but not happens in always. But there is disc preserved in tuberculosis. In pyogenic, is always early disc involvement is more. So already we see these charts. This is another case of 30-year-old man. This is our case. 2 months history of back pain with bilateral weakness and 10 days of febrile illness. It shows that there's sclerosis at the L3, L4 and L4, L4 level. The X-ray shows that, and MRI shows there is hyperintensity at the L3, L4 and L4, sometimes L5, L5 level, and there is epidural collection also seen that. So it looks like a tuberculosis. So one general patient started an empirical TT for this purpose, and patient come to us. We go for the biopsy, and biopsy shows that there is a benign cavernous hemangioma. So anything can happen. TB can mimic anything. So the patient turns to be a benign cavernous hemangioma. We treat already the patient treatment, under treatment for the tuberculosis. So be in always in mind that every case is not a tuberculosis. This is a case of deformity with no collection, no retropulsation, no abscesses there. But patient with history of just trauma 1 year back. And now patient come with for this with we correct the deformity and just tissue disc samples we send for the histopath, and the histopath will come as a gene expert is positive. So this may be this is a tuberculosis case. So anything can happen in this pyogenic spondylodiscitis or any of these cases. So differential diagnosis is sometimes of pyogenic discitis, infectious spondylodiscitis type 1, modic changes, Schmort's nodes, and spondyloarthropathies, metastasis.
Can you conclude? Yeah.
Yes.
Your time is up.
Okay.
Yeah. Can you conclude?
Yeah. So there are differential diagnosis like modic type 1 degenerations also there. Then there is aggressive Schmort's nodes is there for differential of the infectious spondylodiscitis. Compression fracture is also there. So TB is a great mimicker. You should be always learn go for biopsy for this. Sometimes osteoporosis fracture is there, tumors is there, mets is there. This is our case of lymphoma is there. So radionuclide bone scan is a much more sensitivity in early disease of the scan as compared to this. PET-CT nowadays increases also more sensitive in early diagnosis of the cases as compared to this. So clinical feature, laboratory investigation, microbiological investigation, radiology, all 4 are most important in combination for the diagnosis as compared to only single diagnosis. And last is the indication of surgery is the failure of non-surgical treatment, no resolution of symptoms, spinal instability, spinal cord involvement, and progressive neurological deficit. But what defines the failure? What defines the neurology pain? What defines the house spinal instability? How is the compression defined? And what kind of progression? This will tell you my colleagues and all my seniors. Thank you.
Thank you. Thank you. Deepak?
Yes, sir.
You have done a wonderful job. Your lecture was worth 1.5 hours. You have tried to squeeze it in within 15 minutes. Excellent lecture here. Yeah. Thank you.
Thank you, sir.
Apurva, please.
Can you unshare your screen?
May I invite Dr. Kirti Sabnis to please start with her presentation?
And share my screen.
Yeah.
I hope this is.
Yeah.
Am I audible?
Yes.
Yes, please go ahead.
Yeah. So actually, I'm the odd person out in the all surgeons place. I'm an infectious disease physician. I get warm greetings from Fortis Mulund. So I'm going to just talk about practical things what we normally do, as we have already in elaboration seen how each disease presents. So I'm a clinician. My work derives from cases. So I'll quickly go through how an ID physician will approach to an infective spondylodiscitis in a native spinal cord. So this is 50-year-old construction worker, diabetic, had a gradually worsening back pain, was already started on ATT based on some imaging findings outside. Came to us with a high-grade fever and sudden onset quadriparesis with respiratory compromise on the day of admission. So this was his MRI, which already showed a compression fracture and an abscess. On this basis, on an imaging, he was already on ATT for almost 10 days before coming to us. He had a flaccid quadriparesis with a sensory level, required an intubation eventually, and was admitted to ICU. So how do we approach, how an ID physician will approach, or what is a rational, relatively correct approach for these patients? So this is definitely patient is not improving with AKT, but that doesn't make that there is no TB. So this is how it's like a Sherlock Holmes puzzle or Sherlock Holmes case. That's what we approach. Is a diabetic person with a compressive myelopathy with upper respiratory tract involvement with neurological worsening on ATT. So a few pointers for definitely we'll need a biopsy in this era. There are a number of imaging findings. There are a number of clinical features which will tell us about this. It can be, but there is nothing which will actually give us a treatment direction. We have to do a biopsy. So now he has a compressive myelopathy. Whether we should biopsy first or should we start treatment first? He's already on ATT. What to do? So critically appraising, this is a retropharyngeal abscess with cervical spinal involvement. So because he's a diabetic, the commonest organisms will be bacteria rather than TB. So I will definitely like to cover him with a broad spectrum antibiotic. Majority of these are gram positives. So a broad spectrum gram positive cover, because he's not improving on ATT, I like to give an additional MRSA cover. So like this, a native infective spondylodiscitis will be approached by an ID physician. We will definitely in first 24 hours of initiating therapy if the decision regarding open biopsy, decompressing, I'll leave it obviously to my spine surgeons, but definitely I'll need at least a CT guided biopsy within first 24 hours. It doesn't matter how sick will be the patient is. And generally when the patients are so sick, we will come to a few slides. What will be the yield of blood culture? Can we do a blood culture and correlate these blood cultures if it grew something with the infective spondylodiscitis? Yes, there is a data. We'll discuss in the coming slides. So as I said, whether to start antibiotics or not to start antibiotics, or to do a biopsy first, it's like a chicken and an egg question. So a needle biopsy, actually there are multiple studies. One I felt, which I got it with a large number of cases, is published in Open Forum Infectious Disease 2022, which says even if you're not able to do an open biopsy, a needle biopsy yield is almost 50%, backed with additional 20% results by blood culture. So even however your sick patient is, and even if you don't want to plan for a decompression immediately, a CT guided biopsy at a tertiary center, even for a secondary level center, definitely is possible. And if we back up with a blood culture, the yield increases to almost 50 to 60%. Means our empirical therapy can be cut down by almost 60% if we follow this approach. This is, I'm not talking about surgical management. I'm sure it will be dealt with by the subsequent speakers. So very important as an infectious disease physician, whenever the case has been discussed with us, we give maximum importance to the tissue. Swabs have lot of false positivity, like we see. This is a superficial swab from a sinus, and this is a swab from a deep peroperative tissue. So as you see, this is superficial swab is glowing a Klebsiella, and a per-op sample or a tissue biopsy, CT-guided sterile biopsy is giving me MRSA. The treatment guidelines are exactly 180. So if we need to have a team approach and have a better infection control and a lesser operative interventions, specifically in an implant-related case, we need a tissue, or we need a pus, we need a fluid, rather than getting a superficial swab from the sinus. This is very, very important, and I think all the spine surgeons or operating surgeons should take this message. Microbiologists will be really, really easy to process if you give them a tissue sample. And now there are a lot of molecular advances in which we can actually do within 4 hours, we can actually get a resistance mechanism if we get a correct sample. And we can't process anything from a swab, not much things from the swab. So this is again one case who had, again, a diabetic osteoporotic fracture, underwent a vertebroplasty, also had implants in situ. This was the wound after 1.5 months after surgery. Scar is healed. You can see a small bleb here. Then eventually it started having discharge. Now the important timing is by the time the patient comes to us or for a secondary level spine surgeon, the patient is already on multiple drugs. So should we really stop the drugs? Like our patient who came to us first case, he was on ATT already. So whether to stop the drugs or whether to continue the drugs, and how it will interfere your cultures. So the data, if you see this case, yes, we ultimately stopped the antibiotics because our repeated cultures were coming negative. And deep cultures finally grew a typical mycobacteria. So for chronic cases, definitely if it is not emergency, stopping antibiotics gives a better yield, because some organisms like atypical mycobacteria, fungi can be fastidious. Fastidious in the sense they generally quickly become culture negative when on treatment. So the organisms like Staphylococcus or gram-negatives like Klebsiella might remain positive even if you are on antibiotics. So as a dictum, if possible, if patient is not sick, it's ideally better to stop antibiotics at least for 2 weeks. And if you're going to do an open biopsy or taking a deeper culture or going to do a definitive fixation surgery, I'll recommend to stop antibiotics for 15 days and then take a sample, because that will be a better sample than taking on antibiotics. But if you see the results, the studies, it yields mixed results. Majority of the fastidious organisms don't grow, but Staph aureus, gram-negatives, which forms a majority of a chunk of implant-related or common presentations about in elderly spondylodiscitis, we should get a result. So are we missing a bigger picture? Because majority of the patients which presents to spine surgeons are generally elderly people with predisposing heart conditions. So how many of our patients with a vertebral osteomyelitis can have an infective spondylodiscitis, can have a systemic infection, something like a bigger picture, like an infective endocarditis? So this actually is an interesting retrospective review in which almost 40% of the cases patients had underlying infective endocarditis, which was missed because all the focus was given on the back pain and the spinal collection and the abscess. So as a dictum, if these risk factors are there in your patient, can we please look for the heart also, rather than only focusing at the spine? So age more than 75, if they have predisposing heart condition, if they have positive blood cultures, possibility of infective endocarditis increases by at least 30-31%. If there are organisms like like Staph aureus or non-pyogenic streptococcus, then the possibility of infective endocarditis increases furthermore. So if the patient has 2 blood culture positive with Staph aureus, definitely we should screen or look for infective endocarditis. Generally, gram-negatives have lesser chance of causing infective endocarditis. So this is a very common discussion which we normally have. Nowadays, the discussion is less, as Dr. Jayesh also knows what I expect from the samples. I work with Dr. Jayesh, by the way. So, this is very common. If you see the sensitivity, this is a Staph aureus. It is methicillin sensitive Staph aureus. So many of the discussions happens that oxacillin is an old drug. So is it like a newer drugs, a broader spectrum, bigger antibiotics like linezolid work better for MSSA? So it doesn't. This is a typical sample from a disc space with an MSSA. So what to choose? Which antibiotic is better? Whether for always the common MSSA, when it is a susceptible organism, Staph aureus, as we go closer to the first generation of cephalosporins, the antibiotic penetration and work is better. So I think this narrow is nice if you can live with, broad is bad except when you need it. So I think we should follow this dictum everywhere. This will definitely improve our antimicrobial stewardship. So the decision to start antibiotics, decision to switch from oral to IV, decision to give which antibiotic over other, I think it's better to be left at the specialist. But in general, if you don't have like a facility to talk to an infectious disease physician on daily rounds, I will suggest that at least you can have a word with microbiologist, because they will also tell us about the tissue penetration, and duration has to be decided by an ID physician. We'll come to it, how we decide about duration of antibiotics. So there is nothing like an ideal duration of antibiotics in infective spondylodiscitis. It goes with the host, it goes with the pathogen, it goes whether there are implants in situ or not. So generally the duration is, this is from a multi-center observational study, which this was used as a base in IDSA 2015 guidelines, that at least 14 weeks to at least 3 months of therapy is required. We can divide it into 6 weeks of IV followed by 6 weeks of oral. In between, when we transit from IV to oral, it's better to document that there is no additional infection, and if there are implants, there is no implant loosening. If there is blood culture positivity, if the patient is immunosuppressed, then it will require a longer IV therapy.
Dr. Kirti, can you please conclude?
Yes, this is the last 2 slides. I'm just finishing. So we will have again a case discussion. So I'm not adding too many points on tubercular and fungal infective spondylodiscitis, but always we have a very good molecular diagnosis available for tubercular infective spondylodiscitis. So please, we should refrain treating on imaging basis. We should always opt for a molecular diagnosis. Paradoxical worsening, especially in females in infective spondylodiscitis, specifically tubercular, is real and can be dealt with non-surgical measures. And generally, what I've seen is adding a single drug in already a failing regimen of TB. It's strict no. We should not do. If it is happening, if a patient is failing on correct anti-tubercular therapy, we should re-biopsy, reculture. That's the dictum. There can be dual pathologies in patients who are immunosuppressed. And I think documentation of complete improvement radiologically and biochemically is always important. So in a nutshell, it's always a multidisciplinary team which works. Establishing a diagnosis of pathogen is of paramount importance, because for multiple reasons, for better patient's outcome, medical legal aspects, and if avoiding any drug related complications. So with this, I end my talk. Any questions, I welcome.
Thank you. Very good.
Thank you, Dr. Kirti. I now invite Professor S.S. Kale to present his talk on instrumentation strategy in infective spondylodiscitis.
Okay, can you see my screen, everybody?
Yeah. Very well.
Okay, good afternoon, everybody. And after this very nice introduction by Dr. Deepak and Dr. Kirti, I'm going to talk for the next few minutes on instrumentation in spondylodiscitis. So why do we need to instrument at all? I mean, it's an infection. So infection needs to be treated with antibiotics, as Dr. Kirti has said. However, there are some caveats to this statement. We need to immobilize the patient rapidly. If the patient, because of any reason, is lying down in bed and not getting up, then that leads to other problems. So the aim of our treatment, including the surgical treatment, is rapid mobilization. Second, we don't want him to stay in the hospital for very long. Those antibiotics can take some time. And if he is immobile, if he is immobilized, well, then he has to be under supervision. He has to stay sometimes in the hospital for a very long time. So another aim is to shorten the treatment and to shorten the hospital stay. Third, as pointed out by Dr. Deepak, if there is compression, we have to remove the compression. And sometimes removing the compression involves removing normal ligaments or mobilizing muscle or removing some bone, making it a potentially unstable spine. So in the presence of an infection which has destroyed some part of bone, if you remove some bone, the fear is that you may make it unstable, and that is why you need to stabilize. And fourth reason, as again very nicely pointed out by Dr. Deepak Bangale, to correct the deformity. And if there is a malalignment of the spine, to get the spine in the normal alignment. Now, these are the reasons why you need to sometimes go with surgery and not always stick to non-operative treatment. What all do we gain? What are the gains of surgery? One is aggressive tissue debridement. If there is some debridement there, if there is an abscess, you can excise it. If there is some dead tissue, necrotic tissue, you can remove it. A cold abscess can be removed. You get tissue for microbiology and histologic analysis. Very important. Sometimes the diagnosis can be in doubt and you need some tissue. So you get that. Third is decompression. If there is a compression going on, if there is myelopathy, or if you can see it on MRI or X-ray that the cord is getting compressed, decompression of the spinal canal. Fourth is, of course, if there is a perivertebral abscess, you can drain it and restore the spinal alignment, and stabilization is done by instrumentation and fusion. These are the different goals of surgery, depending upon what kind of disease process is present in a particular patient, we might have to do. And so, which are the patients who will, who have more chances of ending up with surgical treatment, which may include, or many times does include, instrumentation. Now, here they analyze some criteria in one of the papers I read. These are some of the factors which lead to increased chances of surgery, including instrumentation. One is the age. Elderly patients seem to have more instability in the spine. Presence of an epidural abscess. Sometimes the abscess needs to be drained. And if the abscess needs to be drained and the spine is unstable, you need to stabilize it. Third is positive cultures. Many cultures are coming positive and the infection is not responding to antibiotics. Fourth, MRSA. If there is MRSA, well, sometimes it becomes resistant to all these fantastic new antibiotics which we have. And then we are left with no choice but to excise the whole thing completely so that we have the bacteria or decrease the load on the body as much as compromised patients heal very slowly. They don't respond to antibiotics. So this, and finally, some patients who have been already started on antibiotics or antituberculous treatment and that is not responding. So this is the scenario in which there are increased chances of us ending with surgery. Diagnosis has already been discussed. All these options, all these things you must follow. A good neurologic examination, laboratory evaluation, which includes urine culture, blood culture, everything else. Imaging of the spine. MRI, of course, is best. It can tell you about soft tissue as well as the bone. If the MRI is not possible because of some reason, huge patient, very big patient, not fitting, or he has a lot of claustrophobia, or there are implants in the body, or there's a pacemaker, you can't do an MRI. And then an urgent CT myelogram or a myelogram with CT will suffice, will have to suffice if you cannot do a myelogram. And the last 3 lines are very important. Obtain a biopsy, as emphasized by Dr. Kirti. You must try and obtain a biopsy as much as possible. Needle biopsy, open biopsy, whichever way you can, you must get a tissue. And these are the common organisms apart from Mycobacterium tuberculi, which affect the spine. Number one, staph resistant is also very common. Enterobacteria, Streptococcus, Pseudomonas, and anaerobic. And these are some of the common antibiotics which treat these bacteria very well. So you can have a choice You can use 1 or 2 antibiotics depending upon which organism and which antibiotics are available. So what type of surgeries can be done? One is, of course, minimal access surgery. And I'm sure Deepak Bangale would have been delighted to speak on this topic. But this 10 minutes is too short to discuss everything. So I'm not going to talk much about minimal access surgery. But open surgery, yes. So there are many approaches to open surgery depending upon where the abscess is or where the deformity is or where the bony destruction is. You can go anterior, posterior, or you can have a combined approach. Now, biopsy, I think I would like to emphasize here, even if the biopsy fails once, I would persist with it, and after some time, use fluoroscopy or use the CT guidance or image guidance or whatever you have and get another biopsy or try one more time to get a biopsy. This is so important that I cannot, less emphasize it. You must try for biopsy one more time before you go for surgery. Before you have to conclusively come to a diagnosis, and for that, biopsy is the best. So why do we need more? These are some of the reasons, I think. It's a tertiary referral center where I work. So we get all kinds of complicated patients, somebody who's diabetic and hypertensive and has immunosuppression or has some liver failure or has other problems. Non-compliant patients, we know that this patient is from 2,000 miles away. He may not come back for regular follow-up. This is we have to do something with which he can go back home and not come back to us for months together. Possible increased risk of side effects when administering long-term broad-spectrum antibiotics. If you tell a patient, okay, you need these 2 vancomycin and something else, and you need to take it for 6 weeks or 8 weeks, but we cannot admit you in the hospital, that's difficult. Some patients, for some, it's very difficult to manage. In comparison to conservative surgery, conservative therapy, surgery allows a safer, more rapid cure of the inflammation, and mobilization can be started relatively early after surgery. So these are the reasons why we sometimes have to undertake surgery with borderline indications. Now, here's an interesting paper which I read. It's a recent paper published 2 years ago. Neurosurgical management and outcome parameters in 237 patients with spondylodiscitis. Now that's a big series, very big series, and very interesting. The data which they have presented. 45 patients had cervical spine problems, 73 in the thoracic, and 119 in the lumbosacral spine. All the patients with cervical spine spondylodiscitis received instrumentation. And in thoracic and lumbar spine decompression, sometimes they did surgery without instrumentation, that is in 26 of the patients, as an immediate surgery. Maybe there was an abscess, or maybe the body was touching the body anyway, so they thought if you decompress and debride, it probably is going to fuse on its own. And in the further 28 patients in the early stages following admissions, while 138 of these patients received instrumentation. And let us see what happened to these. This will give you a gist of how important it is to know about what can happen. A few of the case examples, some of them are from our center, some of them are from my colleagues. Cervical spine infection treated with both anterior and posterior, or segment stabilization posteriorly. An example of a thoracic spondylodiscitis causing probably, there was an abscess in this, we also took out some pus and we stabilized it posteriorly as well. And another picture showing the lower part of the spine, the lumbar region, where we used interbody cages and pedicle screws and rod fixation. And by the nature of the rod, you can see this was done minimal access. So I don't do minimal access. This is probably from one of my colleagues who did all this surgery through minimal access. So here is another way by which you can do. But what happened to all these patients? It was not that there weren't complications. 21.5% of them had complications, out of which 7.6% had recurrent spondylodiscitis. 9 cases, adjacent segment had a problem. Another 9, only the adjacent segment, and the index became normal, but the adjacent segment had infection. So we have to look at the spine very carefully before we decide which level to operate, what level to operate, which implants to use, and The other complications, well, wound healing deficits, CSF leaks, post-operative hematoma, reoperation because of any of these reasons. All these instrumentation problems are listed over here. So the bottom line is 21.5, that is 1 in 5 patients landed up with some problem or the other. However, the fact that 80% of the patients who had these instrumentation did not have any problem. They were fine with this instrumentation in spite of these infections present in the body, is a testament that you can use these instrumentations without much problem, even in the presence of these severe infections. An algorithm, how to go about it, I won't bore you with the details. Just one point I want to make. Nowadays, more and more surgeons go everything, they do everything from the back. You see, the amount of exposure the various approaches from the back give you in the anterior region of the spine or in the vertebral body. The L stands for laminectomy. If you do a laminectomy, you can do that much. Now, if you go a little more lateral, take out the transverse process, you get that much more exposure. If you do a costotransversectomy, not excise the rib, but almost the entire transverse process and a little bit of the rib where the joint occurs with the transverse process, you can get a better angle to the body. And if you do an extended approach where you excise the entire rib head, the extracavitary lateral approach, you can almost get the entire body and do surgery in the anterior part, including instrumentation, including putting a cage. And because of shortage of time, I'm not showing you, but this is a very good approach, this LECA, lateral extracavitary approach. You can approach the entire body, almost the entire body. And if need be, you can do it bilaterally. You can do it on the other side as well and get the spinal alignment and stabilization done perfectly normal. Now, the complications which can occur, biofilm. Everybody is scared of biofilm. Oh, these implants, they develop a biofilm. Biofilm is a serious problem. Sometimes it does happen. But if your debridement, if your removal of the infected material, if your removal of the pus has been more than adequate, then this biofilm development problem is much less than what is feared. However, if you don't excise the debridement properly, if the abscess has not been drained completely, then yes, the implant can develop a biofilm, which is made up of polysaccharides and proteins. They cover the film, which causes bacteria to grow inside this biofilm. And so the antibiotics cannot reach that. And then it becomes a chronic problem. And many times it leads to redo surgery. So you have to be careful about this biofilm and try and excise the entire infected material as much as possible. In the olden times, there used to be a surgery called Hong Kong disease, Hong Kong operation. The Hong Kong operation used to be a very extensive operation where there could be multiple resection, multiple vertebra might have to be excised. They used to approach anterior as well as posterior. Big operation. However, as I showed here, even the lateral posterior approaches can give you a very good approach, and you can do a lot of work without doing anterior surgery. And these are some of the complications which you have to be scared of. The screw pull out, because the bones are not very healthy. So there could be screw pull out. If you're balancing of the spine, if the amount of instrumentation, amount of the screws, the length of the construct is not correct or is not appropriate, it might result in a screw pull out. There might be worsening, neurological worsening, the dural damage, moving the dura around, shifting the dura can cause a neurological worsening. And if there's always a chance that the disease progresses, the infection doesn't respond to the antibiotics. The mainstay of the treatment for this is antibiotics. The surgery is just to take care of the spinal alignment or to maybe stabilize instability. But if the antibiotics do not work, then the disease is going to progress. So the focus after the surgery has to be on appropriate antibiotics. And if you manage all these 4 potential problems carefully in the planning and in the execution of the surgery, and of course in the instrumentation, I am sure all of us can do instrumented spinal fusions, even in the presence of infection, whether it is tuberculosis or Staphylococcus aureus, very successfully. Thank you very much for your attention.
Thank you. Thank you. I would like to make just two comments on Dr. Kai's lecture, excellent lecture. Number one, I would like to recommend that what Kai said, posterior lateral approach by excising the rib head and transverse process is one of the best approach for tuberculosis of the vertebra. And second point, Hong Kong operation failed. One of the reasons for this, they used one leg grafts, that is one of the reasons. Therefore, it was not became very popular. Thank you. Please. Apurva?
Thank you, Professor Kale and Dr. Ramani, for your inputs. I would now like to request Dr. Krishna Kumar with his talk on postoperative infective spondylodiscitis.
Good evening, and thanks to NSSA for this opportunity. I hope my slides are on screen.
Yeah, we can see your slide very well.
Good evening, and most of the aspects regarding spondylodiscitis and its etiology, how to manage it basically, and what is the role of instrumentation have been thoroughly discussed. But in this context, what makes this topic, that is post-operative infective spondylodiscitis, holds good is because the fact that we have, as surgeons, we are always concerned about our patient's health after surgery. And here we have performed the surgery and we don't want any infection of any sort to occur. But this is a very critical situation where post-operative infection in the form of spondylodiscitis, it compromises the good results which we obtain. And for the reported incidence, it is very low, so to the tune of less than 0.5%. But for the patient for whom it is occurring and for the surgeon who treats the spondylodiscitis, being the primary surgeon, it is 100%. So I think it is described very in early 50s itself. But the postoperative discitis, all the tissue planes are already opened up. It is not like a spontaneous spondylodiscitis. So if you see the diagram for depicting what is meant by the levels of infection, we can say that just beneath the skin, the inflammation has started. And even though the pathology may be at the disc level, it may be subcutaneous, it can be deep soft tissue, or it can be an organ space. So the patient leaves the hospital with a good thank you note. And typically the period between surgery and onset of symptoms is 2 weeks. It can be 1 week or it can be a month. But usually the thank you note will turn into something like severe back pain, muscle spasm, fever. I didn't have the symptoms before. Why should it happen again? The patient comes back. And as discussed, there is not much difference between a spontaneous spondylodiscitis patient profile with a patient profile for post-surgical spondylodiscitis. Almost the same. And imaging also, it has been excellently shown here by Dr. Deepak. The plain radiograph almost always is telltale. Like in this patient, unfortunate patient, after 3 weeks came back with severe pain. And MR almost always is diagnostic. And you can see the disc fluid sign, the irregularities of the end plate, edematous changes in the adjacent vertebral bodies, and of course, look for the paravertebral and psoas muscle. That also will give you a clue that, yeah, we are dealing with an inflammatory process and not something which is related to the primary disc pathology alone. And there is something which confounds most of the MR findings, because most of the present day spine surgery, especially MIS, is centers around instrumentation, the pedicle screw, which causes a lot of artifacts in the MR. So how do you distinguish a spondylodiscitis in a patient who is already instrumented? So the pedicle screw fluid sign will give more, if you look for it, then if you find it, then it gives you better. Like this is the pedicle screw fluid sign as seen, depicted by the white arrow. The normal artifact does not have that fluid intensity all around, if you notice. So this is the normal artifact versus pedicle screw fluid sign. And CT scan has already, it is an aid to biopsy. It is not a diagnostic tool alone, or you need not go up to the level of a CT scan to diagnose it. You have enough clues from your X-ray and MRI. But soft tissue collection, areas of early bone destruction, which will point you to the area where you want to take a biopsy. And as already spoken by Dr. Kirti, the yield of culture, the doubt is it aseptic or infectious process? Because you already done a surgery, there is inflammation all around. But positive cultures do not rely on it always, but you have to repeat the culture often. One negative culture doesn't mean anything. But in post-surgical spondylodiscitis, 25% of patients even may be culture negative. But what happened? This is one of the pertinent questions even asked by the relatives who are most of these patients will have a very influential relative like a doctor, brother. They will say, did you inoculate the offending pathogen into that avascular disc space? Did you cause injury to the enclave? Was there a hematoma? Or we have minimally invasive surgery, so did you really see what is going on inside? So these are the questions which are asked by the anxious people. And there is very limited evidence that MIS will decrease the risk of this spondylodiscitis. And upcoming investigation, FDG PET, it is very, very sensitive, very sensitive. So, but in the early stage of the disease, when in the presence of hardware also, it will pick up spondylodiscitis. But after 2 weeks, its efficacy is almost picking up is like MRI. And of course, rely mostly on C-reactive protein more than ESR, because C-reactive protein, it will return to normal, near normal, rather than ESR, which will take time to return to normal. Etiology, this has already been discussed, and procedure-related risk factors. If you're longer duration of surgery, if you have an incidental urotomy, lot of blood loss, need for transfusion, there are always people circulating in the OR or multi-level revision surgery. And prophylactic antibiotic treatment, it is always better to have a prophylactic antibiotic treatment, but it should depend on the antibiogram, last 3 months antibiogram of your hospital or your setting before you decide. Because if you see the literature, various combinations have been described, but rely on the infection control team of your hospital, discuss the antibiogram and the bacterial flora which were there last 3 months. And why fixation? Professor Kale has excellently demonstrated why we should fix. Holds good for infective spondylodiscitis after a surgery also, because fixation stabilizes the spine and instrumentation after radical debridement will not increase the rate of recurrent infection and immediately stabilizes the affected segment. And prevention is always better than cure. Please instruct your team to follow meticulously universal precautions, aseptic techniques. Patients should be optimized before surgery. Don't fast track a surgery for a patient, especially with diabetes. Proper use of perioperative antibiotics, and close the door, shut the door before you operate the patient. That is the dictum, like we do VP shunts, and blood transfusion only if very, very necessary. So this is one of the cases which we got with, and MRI showed a disc, operated, very good
7
outcome.
o'clock.
And the patient got readmitted. The CBC was normal, ESR raised, CRP raised, but the surgical wound has healed excellently well. But the MRI gave us the clue, and we did the debridement of the disc space, took biopsy, copiously irrigated, and the biopsy yielded pseudomonas. And follow-up, if you see, CRP has drastically come down to normal, seeing that the patient has responded. ESR is still remaining high. So CRP is the better indicator. Non-surgical management, okay, you can try most of this, but limit it to 4 to 6 weeks. Do not go beyond that limit. And it includes immobilization, monitoring, etc. Repeated MRIs can be done. But if you see this, it heals with a collapse. So you are leaving behind with a sort of unstable spine. So here come, and this is the amount of instability which has caused 1 year after conservative treatment. So surgical management, other than a biopsy and an evacuation of an epidural abscess, you can prevent deformity from occurring. You can prevent the vertebral destruction to get more worse, and of course the failure of nerve. And this is one interesting article which may be of interest in this context, that there are 3 types of spondylodiscitis which is being described. Type A is without biomechanical instability. Type B is without segmental instability, but a lot of destruction around, as seen the MRI here. and type C, where there is epidural abscess, and a lot of them, maybe one of the scans which we don't want to see, especially in an operated patient. So the management strategies put forward by the group which analyzed is that the type A is the one where you can somehow get away with orthosis immobilization or a percutaneous stabilization. But the type C is the one which definitely requires open debridement and stabilization. And of course, we have now bioceramic beads coming into view. This is our work, which was now transferred to the technology where the bioceramic beads will deliver the drug. So make use of that and stabilize it. Use bone graft, copious use of bone graft. Do not fear that the bone graft also will get infected, and put bioceramic beads. And instrumentation has already been described. Titanium implants are always preferred because if we go for the low-cost implants, then future MRI will. So general guideline is antibiotics, okay, you can try, but always try to attain a biopsy and culture. Remove the loose infected bone graft. Implant removal only if necessary, and close suction irrigation with maintenance of nutrition. And of course, vancomycin powder. Most of the surgeons would like to use this as an adjunct. So to conclude, the severity of post-operative spondylodiscitis is almost like 3 times more morbidity to a patient because he has already undergone a surgery. And the key is to prevent it rather than letting it occur and manage it. Thank you so much.
Thank you, Dr. Krishna Kumar, for the very, very elegant and an informative talk. And with the permission of the chair, I would like to invite Dr. Sukumar Sura for the last talk of this session on the role of endoscopy, the diagnostic and therapeutic implications. We can see your screen, Dr. Sukumar. You're not audible.
Yeah.
Can you see the screen?
Yeah.
Just make it into slideshow and then we can start.
Okay.
Yeah, we are good to go.
Yeah, good evening, respected seniors and my friends. Thanks for this wonderful invite, which is a very important topic. Almost my previous speakers have spoken about in length about the causes, role of instrumentation, and the post-op disability a patient develops when he develops infection. My talk today is, can we use endoscope in some situations, either de novo spondylodiscitis or post-op spondylodiscitis. There are a few occasions where we can use endoscope and get away with again redo open surgery and increase the morbidity of the patient. So as we have already heard that spondylodiscitis is just a mainly infection of the end plate. So it's a end plate disease. All the beginners or the youngsters should know it is not only the disc infection, it is the end plate infection, which is very important to treat. And again, this we have seen this in previous slides where the confirmation of this spondylodiscitis is either through radiology and some kind of biopsies. Most of the time, this biopsy, Professor Kale was mentioning about it. First biopsy, if it comes negative, always try to go for a second biopsy. This is very, very important point sir made, because second biopsy can come positive and it guides us to the management better. So most of the time it is around 30 to 50% of time you get a positive result in first instance. So again, modalities, we have so many modalities, either non-invasive or invasive modalities. The previous speakers, I don't want to waste time here. So again, principles are very clear. Any infective material, removal of that, reducing the load of the infection gives faster results. So if it is not getting better with antibiotics or anti-tubercular drugs, then better is go for a active aggressive debridement, which leads to the improvement of the patient symptoms faster. So again, my topic today is what is there any role of endoscopy today in spondylodiscitis? Yes, there are few occasions. It helps as a diagnostic modality and therapeutic modality. Diagnostic modality, when we have done a needle biopsy once or twice, but still patient doesn't want a open surgery, then definitely we can go either transforaminal or interlaminar approach, especially transforaminal approach, go into the disc space and try to debride and at the same time take a aggressive culture biopsy and send it to a material for culture, which most of the time yields better result than a simple needle biopsy. Therapeutic, yes, there are indications where when you can do a thorough debridement and either use a graft, pack the graft into the space, or even do a proper T-lift. So it can be done in two ways. One is a transforaminal technique and interlaminar technique, which we usually do for any disc surgery or stenosis surgery. The same principles can be followed here, but need of the caution here is because the space is infected, the problem, the scope, the sheath, everything can plunge deeper, can go into the anterior abdominal wall or go into the opposite side because there is no resistance here. The annulus is thinned out, diseased. So the word of caution is be very, very careful. Use more X-rays or CM images to be inside the disc space all the time. Most of the time, end plates might be damaged, so you might harm more end plate damage than usual. I just go through the scenarios, few scenarios. This is a first case where patient was a diabetic and he developed a de novo infection of the disc space at L3, L4 level, L2, L3 level, and he had a severe pain. He's an elderly man, didn't want any surgery. The needle, unfortunately, the first CT-guided biopsy came negative. So antibiotics were started, but no improvement. Then I did put a needle there. You can see the needle here going into the, and you can see a fluid coming out. Nice. I have put a needle into the intradiscal space, and I'm aspirating the content there. And there is a syrup, sanguinous, and some purulent material coming out. And that I sent it for culture. And this came as E. coli, which was not picked up as CT guided, unfortunately. So then we gave appropriate antibiotics for him. And also I did a thorough debridement. So put an endoscope, did a thorough debridement and removed as much material as possible. And we gave appropriate antibiotics for 6 weeks. And patient, luckily, the open surgery was avoided here in this patient. He became well. So second case is a young male, 21-year male. He's a worker at Dubai. He's a laborer in Dubai. So when he came here, he had a severe back pain. MRI was showing end plate destruction with a cavity here with the purulent material. So again, we did a CT guided biopsy. We could not yield much because it was entirely the paradiscal material was less, and so we couldn't find anything. So endoscopic procedure was done, transforaminal approach. You can see the bottom two images where I am using a articulating curette to curette the end plate material nicely, and both end plates are damaged in the center. So being a young patient, we gave him a chance, and post this came as AFB positive, and we started him on anti-tubercular drugs, and patient is doing well, and it has sclerosed and fused very well at that level. We avoided a surgery in this patient, and definitely it helped the patient much. This third scenario is a young lady, ophthalmologist by profession. Patient underwent a microdiscectomy. Patient was doing fine for 2 weeks. Later, she developed severe back pain and 1 episode of fever. So she was empirically diagnosed as discitis. Then she was treated with almost 3 months of antibiotics, but there was no improvement. Patient had severe back pain. So they came to me. Then we discussed in depth, So we thought we'll go inside and debride the entire space. And because she had out of proportion back pain, so what I did was go transforaminally, debride the entire area, and material was debrided, and space was packed with the graft. Then a patient underwent a pedicle fixation. So interbody graft was placed, and patient was fused. Very rare, very sharp, unusual. The finding was the culture came as Aspergillus niger. So fungal. This further it was uh, special strains were used, and it came as filamentous fungi, came as Aspergillus niger, and it was sensitive to voriconazole. So patient is started on voriconazole, and she was given voriconazole for almost 3 months. Then patient symptomatically became better, and now 1 year follow-up, patient is absolutely doing fine. This is one more scenario. Young individual patient underwent a microdiscectomy and developed symptoms within 5 days of surgery. Such patients again we see often in our practice. So the point I want to mention here is patient never had any fever but had out of proportion back pain. So I did a contrast scan. It was showing there was a inflammation there around the disc space. And here the dilemma was whether it was infective or it's just a aseptic inflammation of the disc material. So ESR was raised, CRP was raised, but there was no fever for him. And he had taken antibiotics almost for 2 weeks before coming to me. So given the chance that there definitely either aseptic or septic spondylodiscitis is there, so we discussed with the options with the patient. So this patient again endoscopically thorough debridement was done, and patient was again fused. Here you can see in the image bilateral scopes have been placed, sheds have been placed, thorough wash and debridement has been given, and cages are placed. The cage, you can see the cage in the first one, the end plates are well prepared, and you can see the sheath of the opposite side, and end plate is well prepared. You can see the good petechial hemorrhage from the end plates. All the dead material, dirty material is debrided. And in the second image, you can see the cage after packing the graft. We have put a cage there because end plates were healthy. It gives a faster fusion. So we have put a cage also. And this is a post-op, and patient is doing fine. The last case of the day, this patient was done, a 2-level fixation was done, and 2 months later, the patient was a diabetic, and 2 months later, patient started having back pain and fever. So he had urinary tract infection post-surgery, and he developed the cage migration, probably because of the discitis. So this patient, again, if you would have planned, we have to go through the same incision and do a open and do a thorough debridement and remove the cage. So I offered him a chance of endoscopy. We try endoscopy. If cage is not coming out, then I will convert into a open surgery. So luckily the cage came out. It was very loose, and I put an endoscope there, and cage came out. Cage came out, and you can see the cage coming out from the wound. I removed the cage endoscopically, and the entire cage was removed, and thorough debridement was done. And you can see the right side image, and thorough debridement has been done. So curitas and post-op, patient is doing fine with antibiotics. Again, it came as staph aureus. So patient was given appropriate antibiotics for 6 weeks, and patient improved. So avoided one more open surgery for him. These are some rare scenarios where we can offer endoscopy for such patients, either de novo or post-op infection. Endoscopy can be offered in few situations. Definitely, it will help them. Thank you.
Thank you. Thank you. Thank you very much. Yes, please. Apurva?
Yes, sir. Sir, thank you so much for all the lectures, Professor Ramani and Professor Kale. If you would like to ask some questions to the presenters, we'll begin with that. Otherwise, with your permission, we'll go on to the case discussion.
I think we should go to the cases.
Okay, sir. I'll just share the presentation. So this is the first case. For the case discussion, I would like to invite Professor Ramani, Professor Kale, Professor Krishna Kumar, and Dr. Kirti, our infectious disease specialist. This is the first patient who is a 33-year-old male with no comorbidities. He complained of mid-back pain since the past 8 months, which was insidious onset and gradually progresses. The VAS score was approximately 5 to 6 out of 10, and on lying down, the pain was lesser. He complained of a constricting band-like sensation over the stomach since the past 3 months. He had a weight loss of around 6 kgs over the past 5 months, and at presentation, he had a urinary urgency, but the bowel functions were intact. Clinically, he had tenderness over the D3 to D10 paraspinal region, no spasticity, no wasting, no hyperreflexia. Power was fairly well preserved, and both the planters were flexors. He was an obese patient. His BMI was 31.7. The USG abdomen and HRCT test were done, which were within normal limits. Now, these are the images for the patient. We have the chest X-ray in the beginning, which seems apparently normal. If we see the MRI scans, this patient has a predominantly D7, D8, D9 region paradiscal infection. As has been highlighted, we can see a subligamentous spread of the infection. We can see skip levels. Even the D3 vertebral body is involved. And on the axial imaging, we can see not only D8 and D9, but also D5, D6 levels are quite involved. The entire collection is anteriorly, more on the right side. So I would like to begin with Professor Ramani himself. He has had an extensive experience of treating these patients in Sion Hospital. I have been fortunate to see his collection and his experience. So, sir, for this young male, what would you advise and what would you plan to do when he presents?
Your history, your presentation, and your images leave us no doubt that it is a tuberculous infection. Fortunately, over the 8 months, has not much affected neurologically except urinary issues, but no paralysis or anything like the neurological deficit. We'll straight away go ahead in this patient and treat him as tuberculosis. I will ask Dr. Kale to intervene at this moment and take it further.
Yeah, so what we teach, this is very, very good illustration of, radiologically multiple vertebral body involvement leaves no doubt. It could either be multiple body involvement could mean either a malignancy, metastasis, or tuberculosis. There is no third diagnosis over here. So, and considering the age and presentation, everything points towards tuberculosis. However, I would still like to do a biopsy and get some tissue. It'll tell us two things. It will confirm the diagnosis of tuberculosis, and it will give us some tissue or some bacteria where we could establish the sensitivity of this bacteria. Which drugs is it sensitive to? And then we can modify, because nowadays the expense of MDR and MDR TB is quite high. So I would still do a biopsy in this patient, and I would do a CT guided biopsy. If that fails, then another attempt at biopsy, but I would do everything to try and get some tissue.
Okay, I would like to request Dr. Krishna Kumar and ask if he would need any more investigations in this patient before he plans the final treatment.
As illustrated earlier, with the strong suspicion of chronic inflammatory disease, tuberculosis in mind, but the only odd point I would say would be the deformity which has already set in without much of vertebral body, evident vertebral body destruction. So there must be some kind of paraspinal involvement also, or some kind of disease spreading out of the primary vertebral body per se, which is amplified. So I concur with Professor Kale, biopsy and then proceed. Biopsy and then proceed. That would be my choice.
So my question is, for these young patients, would you recommend to get HIV testing done or a retroviral antibody profile done?
All the more important immunocompromised states definitely would like to have this kind of flare up. So work up for immunocompromised states as well as some kind of hidden primary malignancy which would be presenting, very rare, but even testicular malignancies can spread along the venous channels. So that would be my take.
Apurva, this
Yes, sir.
what Dr. Kale commented, that he has got so much pus, especially paraspinal,
Yes, sir.
Was CT guided aspiration or biopsy is going to be positive. I don't think it will be not, CT guided will not be very informative or anything that you have to do it again. However, I will ask Dr. Sura whether he would think of straight away going for endoscopic biopsy in this case.
So Dr. Shura is, I think he lived because of some emergency.
Yeah.
Oh,
Goel sir is also with us. Welcome, Goel sir. Please participate also in.
welcome, Professor Goel.
Thank you, Jayesh. Thank you, Apur. I'm enjoying the discussion. I'm enjoying the presentation.
Yes.
Obviously, we have the largest experience probably in the world in these kind of infections, particularly tuberculosis. Tuberculosis is endemic in our country in particular, and no question, with experience of Dr. Kale and Dr. Krishna Kumar in top institutes of our country, this must be a very solid experience. As far as, the controversial things are concerned, about, as Dr. Kale mentioned, about, instrumentation in an infective situation. If there is infection and you are putting instrumentation, that was one very interesting discussion by Dr. Kale. And I have a feeling, as Dr. Ramani also said, that CT-guided biopsy is positive in these cases in most of the instances. And whether we need any biopsy kind of situation, I am wondering in this case in particular, which is, the shape of the body is quite okay, and there is no impingement on the dura or on the cord, whether any kind of stabilization will be mandatory in the long run or may not be mandatory. I would like to know for my own interest. Dr.
Dr. Kale, Dr. Ramani, if you could comment.
Sir.
See,
the need for future stabilization.
Yeah, the question is here. He may be having a gross infection. The question is, does he have instability? At the moment, it does not indicate any instability in spite of the fact that very small portion of the vertebra is affected. So now the answer is very strictly antibiotic treatment. But watch him. If he develops any instability in future, that will be the time to stabilize the spine with instrumentation. Dr. Kale, please, what is your opinion?
Yes, sir, absolutely. I mean, all his MRI and X-ray point towards solid spine. It is not unstable. So here we need to just confirm the diagnosis. And the one thing is confirming the diagnosis. The second thing is getting the antibiotic susceptibility of the organism.
Yeah.
I think in today's age and time, it is important to know whether it is resistant to rifampicin, whether it is resistant to INH, if it is a resistant tuberculosis or not. So that is one more reason why biopsy. By biopsy, I don't mean you go do an open biopsy. No, whichever way you can, a CT guided. If you see the MRI picture of the axial image, you can see a localized collection of pus. If by radiological assistance, we can reach that soft tissue collection, if we can get to that, we will get all what we need to establish the diagnosis and to know the susceptibility of the organism to different antibiotics. I think both purposes will be served. If not, then CT guided, we can go with a bigger biopsy, not a fine needle, but a bigger biopsy, and get the tissue as well as confirm the diagnosis. As far as stabilization is concerned, I concur with Professor Ramani. I don't think it needs any surgery right now. Apart from confirming the diagnosis, it doesn't need any surgical intervention.
Sir, here are we introducing one so-called guideline by all the experiences that any kind of tuberculosis, as it is an early disease, we can say it's early disease, no instability, no spinal cord compression. Are you saying that CT guided biopsy should be, the cornerstone of diagnosis before we start ATT? Are we saying that because the old criteria was that all the old literature and treatment was just on clinical and radiological basis, we used to start the ATT, wait for 3 to 4 months. Then if there were resistant or patient not improved, then we used to prescribe the CT guided biopsy. So are we saying that
Yes, you have to answer this question even in 2023 on 2 counts. If the patient is in the city, you must do CT guided biopsy and then start the treatment.
Okay.
But the patient is in the village and it takes time to come to the city, then what you see, the second option is also to be started. So we have to work on the dual principle, urban and non-urban patients. I think that still counts for us because our communication between urban and non-urban is not all that adequate. And what Kale made one point very important that I would like to stress again, that there was a time when we gave just AKT, this, that. AKT we consider as a one drug like that, one packet. But today, in 23, our modern technology allows us to have antibiotic sensitivity for each drug separately. Or do you say? Yes, that's all. Yeah. So it's very, very important in the cities to do all these tests and finally come to the correct conclusion.
Fine.
So last 2 points for this case. One is, Dr. Kale, would you advise an external orthosis or a Taylor's brace for this patient? And second is, would you like to do a CT scan of the dorsal spine in this patient?
Well, it just adds to the expense. You see, the CT is going to tell us the exact nature of the bony involvement. But the very fact that there is hardly any reduction in the height of the vertebral body. If you see the height of the vertebral body, measure each body and compare it with the ones above and below, you will find no difference. So there is no collapse. It's only part of the vertebral body which is involved in this infective process. So right now, it doesn't need any stabilization. And the interesting thing is that the thoracic spine per se is very stable. There is the big rib cage attached to it, and there's the sternum in front, and there's hardly any mobility in the thoracic spine. So per se, the thoracic spine is much more stable. However, in the lumbar spine, in the cervical spine, you have to think about other factors. But thoracic spine, unless there is a clear-cut indication of instability, I would not go for surgery. As far as orthosis is concerned, I know, everybody knows how effective the Taylor braces are and how effectively the patient wears them. It is, I don't know if it is really helping at all.
Sir,
unless there is instability, say in a 80 or 89 or 90-year-old person, there is some vertebral body collapse, there is a osteoporotic collapse, the surgery is not indicated, or there is severe pain, then maybe to restrict some more movement, you can give some Taylor brace, or you can try to brace the patient. But this young patient, 38-year-old, he understands very well. His thoracic spine is going to be more stable. There is that rib cage attached. There is no mobility in the thoracic spine. So I would not unnecessarily burden the patient with a brace at this moment, unless there is some clear-cut indication.
Sir, what is the protocol in names? Suppose in this patient, how long the ATT Is first phase, second phase, 12 months, 18
Yeah,
months?
look, this period of ATT is, you can keep discussing till the sun goes down until the sun rises the next morning, and then we will still not have the correct answer. There is no right answer to this question. The revised national tuberculosis policy clearly states pulmonary tuberculosis X months, extra pulmonary tuberculosis this many months, osseous tuberculosis this many months. So if the TB, if it happens in the femur, our community medicine people and the RNTPC people keep asking me, why are you giving it for more than the recommended dose? Is the vertebral body behaving differently than other bones in the body? No. Brain, I can understand. Sometimes the deep-seated lesions in the brain or brain stem, or they get walled off, etc., etc. But osseous tuberculosis, there is a clear-cut RNTPC, and they say that please follow the revised national tuberculosis policy. Please do not over-prescribe tuberculosis drugs. And the best part is, if the patient is referred to a TB center, he will get the drugs free for that period. But if you continue to give the drugs more than the recommended period, he will have to buy from his pocket. Because the TB center people say, no, it is not recommended.
It's very important.
You know it very well that the MRI picture is misleading. Sometimes it still shows you a lesion, but clinically the patient is absolutely all right. So what do? Do you keep treating the MRI, or you keep treating the patient, or you keep treating or following the guidelines? I would suggest follow the RNTPC guidelines. At least there will be uniformity of treatment all over the country, at least in this one factor. And then if we see that even after following the guideline, this period is not enough, then we can always argue that, look, we have all been following the guideline, even then it is not getting healed. So there has to be something done about it. But if you don't follow the guidelines, we are going nowhere. You can keep giving for 2 years, 2.5 years. Somebody is giving for 6 months. Somebody is giving for 1 year. It doesn't lead us anywhere. So what I keep telling in our department to our residents, please follow the revised National Tuberculosis Program guidelines. That's all.
Dr. Kirti,
Thank you, sir.
infectious disease specialist is with us. Dr. Kirti, can you just summarize that revised RNTCP guideline for spine? What is
So the revised RNTCP guidelines, as we already discussed, whenever we are suspecting TB, even before the diagnosis, if you're suspecting TB, the patient should have an HIV test always. That's a must. Am I audible?
Yeah.
Second is we have to, whenever possible, the empiric AKT is kind of now obsolete. We have to make every attempt to get a culture sensitivity. Gene expert is a test which is rapidly done on any of the tissue you get. Sensitivity for extrapulmonary like spine will be low, but it is not less than 50%. So your 50% of the cases, definitely you'll know the organism within 2 hours with the rifampicin sensitivity. So if it is a drug sensitive TB, Gene expert, if we send, it is not an alternative for AFB culture. So you also have to send an AFB culture, because sometimes we can get INH monoresistance, isoniazid monoresistance, or rifampicin monoresistance. So it's not HIV, gene expert, AFB culture, and histopath. These are the 4 things should be done in this case. Also an aerobic culture, because sometimes we do get nocardia or pseudomyeliae, which can have chronic osteomyelitis picture like this. So the treatment duration will be, if it is a drug sensitive, with a complete response in the sense pain is gone, largely the collection is disappearing, 9 months. If it is a drug resistant TB, then it has to be, we have to also look at focus anywhere else. And we generally treat for 18 months if we are treating with oral drugs like Bidaquilin.
Apurva, we can go for second.
Yeah. Okay, thank you so much. This is the second patient with a 25-year-old female who is a housewife and has no comorbidities. This case has been given to me by Professor Goel, and I'm thankful to him for the same. So this female presented with a nagging neck pain since 1 year, which was insidious in onset and gradually progressive, and increased with change in posture. There were no relieving factors. The pain was severe. The patient complained of a VAS score of around 8 to 9 out of 10, accompanied with severe weight loss and loss of appetite. She did complain of dysphagia over the past 4 months with hoarseness of voice. There was no breathing difficulty as such. She had a spastic quadriparesis and was using support for walking since the past 2 months. She had urinary urgency and constipation at presentation. Clinically, she did have grade 4 spasticity and hyperreflexia. The power was almost grade 3 at all the joints. The plantars were bilateral extensors and she had a spastic gait. She was a lean, thin female with a BMI of 23.6. And these are the images. The chest X-ray just show a mild infiltration and a consolidation on the right middle lower lobe. The cervical spine lateral X-ray shows a clear-cut destruction of the C3 vertebral body. The MRI sagittal image shows a epidural abscess with severe cord compression. The CT scan and the 3D recon demarcate the pathology very clearly. And the actual CT shows a near complete destruction of the body of the C3 vertebrae. The C1, C2 joints, however, appear to be normal and unaffected by the pathology. So I would request Professor Goel himself to please start the discussion for the case with his line of management.
I would like to hear the views of others before, I would like to really, this is a complex issue. The whole body is gone. Patient is having very gross neurological deficits. There are quite severe radiological manifestations. Of course, this patient needs to be, there needs to be some kind of decompression and some kind of fixation, all right. And you cannot wait for drugs to act or things to act before she becomes completely quadriplegic. So it is quite an emergency kind of a situation. So let us see what others have to say.
So Professor Krishna Kumar sir, can you please comment on the management for this patient?
There is definite cord compression, which is seen in the MRI, and the bone destruction evident from the CT scan. And in the X-rays, the parapharyngeal space appears to be significantly widened. So the possibilities could be some kind of a parapharyngeal abscess, which has caused extensive bone destruction of the vertebrae, as well as the it has invaded along the lines of the PLL, reaching posteriorly, forming the epidural abscess, compressing the cord. That would be the first stage. If constitutional symptoms were also present, and of course, immunocompromised state to be checked. So that would be the first stage. And the other rare possibilities, other than infective inflammatory, would be that of hematopoietic malignancies. Some of them quite behave like this in young individuals. These are the two takes on this. And as Professor Goel already commented, we cannot waste more time. We have to act in view of the high cervical cord compression.
So, what would be your surgical plan of management for this patient?
It would be an anterior approach and debridement, evacuation of the abscess, the pathological tissue for both culture as well as biopsy, and an anterior stabilization.
Okay, so would you consider traction for this patient at the time of presentation till the time you take her to the operating room?
Usually, no. We usually, it depends on the door to OR time, especially. But if there is any delay, traction would be a good option. But I think better to fasten the surgical process rather than traction.
Professor Kale, if you can please give us your inputs.
Yeah, if you see in the X-ray as well as in the MRI, the airway is getting constricted. You can see that the trachea is getting constricted. So this is like an emergency. And in the history also, there was some problem with swallowing.
Yeah.
So the patient is unable to eat, and shortly, if we delay, she will be unable to breathe. So it can't be more emergent than this. So we have to quickly operate on her. And the compression is all anterior. So my approach would be anterior. You approach anteriorly. And in the neck, all these anterior approaches are, well, at least the neurosurgeons are quite well versed with these kind of approaches. And for us, it is not going to be a very difficult job to approach this. Remove the extensive destruction of the body. Remove that dura, clean that dura. You see how the dura is badly compressed. We have to relieve that anteriorly. Get all the material off the dura. Get a good interbody spacer. You can use anything, whatever you want. Something to bridge the gap between C2 and C4. And then to stabilize that, to keep that in place, you need a plate on top, and you need to fashion some plate. If in case you don't have a perfect plate, you can fashion a titanium cage. Cut off some portion, leave some portion anteriorly on one side of the cage, so that the cage itself can be screwed onto the C2, acting like a plate. All kinds of things are possible. But the crux of the matter is urgent surgery, anterior surgery, decompression, and stabilization. Those are the key elements.
Sir, only anterior, or you would like to do a 360?
First anterior.
Only anterior.
Dr. Sukumar is not there. Professor Goel, back to you for your comments.
I don't remember this patient now. Apurv, tell me if I have done something or what I have done. Just I don't remember this at all. So just elaborate what was done and what was the outcome.
So, sir, considering the extensive neurological decline, a decision to first stabilize the spine in view of instability was taken, which was done posteriorly first, and then biopsy and a debridement was done anteriorly.
Do you have the pictures?
Unfortunately, no, sir, because this was in a government setup, so I don't have the post-op scans.
Okay, and was it tuberculosis?
It came out to be tuberculosis, yes, sir.
Very good.
Here I would like to just add, in such a kind of scenario in which patient have a respiratory deficit and quadriparesis, when patient came in emergency, the early traction and stabilization, almost 3 to 4 kg of weight in extension, would give a little bit relief the spinal cord compression till we prepare for the surgery. Maybe sometimes it helps.
See, my take on this case was, probably I just don't remember this case, but my take is, you see there is a purulent material, okay, behind the cord, in front of the cord, purulent pus, that can be very, you reach it and you can evacuate it. And most important is, you see the bodies of C2, C3, C4 are all diseased bodies. So if you have to do anterior fixation, that will be quite an elaborate fixation. On the other hand, if you go from behind, evacuate this pus evacuation from behind, you have space. I'm sure there must be some corridor to enter into the vertebral body, into this purulent material, and then have the passage right in front. And then the whole posterior elements are completely intact. And you can do a solid posterior facetal fixation in a very elaborate fashion. So anterior fixation, I'm not sure what kind of anterior fixation, whether to do C2, include the C2 body in a diseased body, C3 is gone, C4 is diseased. So it will require quite an elaborate fusion. And of course, but my feeling is, considering that this is majority is liquid and purulent material, you can enter from behind, evacuate the pus relatively easily. And then you have the posterior elements which are completely solid and normal, and you can do C3, C4, C5, C6, whatever fixation in a very quick and easy and stable and solid fashion. So that must have been my point of view in this case.
Kale sir, just a quick question.
Yeah.
Had it been the pyogenic abscess, this is the same patient, and you are going to decompress it, still you want to put an instrument here?
Yes.
Yeah, there is, like I said, that is the whole presentation was all about. Don't be afraid of pus and instruments. There is no need to be afraid of pus and instruments. Another thing I want to point out that, whenever there is this abscess creates its own space. So even if you go anteriorly and you remove that pus, it will give you enough space. There will be very beautiful space to fix from C2 to C4. Very nice space. the abscess itself has created that potential space. And if you evacuate, if you remove all that debris and the abscess and the pus, that will give you enough space to put any kind of instrumentation. You can put a cage instead of the body of C3, make it straight, and fix it with the plate. And the top end of the plate is in C2. And C2, you can angle the screws a little bit vertically. And in C4, it will be right in front of you. And depending upon how the screws are going in the body, or you can even do a CT scan before there is a CT scan, I think. You can know exactly how bad or how good the body of C4 is. Maybe you can go up to C5 to put the lower end of the plate. So all you need is a buttress to keep that cage and bone graft in place till it fuses. And if you're doubtful, if you're still doubtful about your implant and if your solidity of your implant and the screws, then you can supplement it by doing a posterior fixation, a short segment posterior fixation, just to make sure that your bony fusion occurs before your implant fails.
Sir, in this case, would a fibular graft offer any biomechanical advantage over a cage and a plate?
I couldn't get your question. Can you repeat it, please?
Would a fibular graft
offer
any biomechanical advantage?
You can use iliac crest, you can use fibula, you can use a titanium cage, you can use whatever you want to use. See, the idea is to decompress. The idea is to get that material out of the dura. Idea is to relieve the swallowing. Idea is to relieve our breathing. Idea is to relieve our myelopathy. And once you have done that, the next step is stabilization of the spine. Now, stabilization, well, you can do it, there are so many ways to stabilize. You can go posterior, you can go anterior and posterior. But if you get a good solid fixation anteriorly, there is no need to disturb the normal anatomy posterior.
Okay, sir.
Apurva.
So, we'll go to the last case. This is a 43-year-old.
7:50. Should we go ahead or should we conclude?
So we'll finish it off in 5 minutes.
Fine.
With the permission. This case has been given by Dr. Jayesh himself. This is a 43-year-old office worker who is diabetic, complaining of low back pain since the last 6 months with right radiculopathy. No weakness, no fever, neurological functions intact. He had paraspinal muscle spasm with normal reflexes, normal power, with intact sensory motor neurological status. His MRI spine was suggestive of an infective etiology at L4, L5 level, and the CT guided biopsy the first time came negative, and the aerobic culture also came negative. These are the images which we have. This is a X-ray in flexion extension, which shows the lytic lesion at L4 and L5. The MRI, the T1, the T2 images confirm the pathology, and this is a contrast image which shows an extensive involvement of L4, L5 and the superior end plate and the body of S1. So I would like to first ask Dr. Deepak Bhangale for his views and the plan for management.
Hi, Apurva. He's a diabetic male, neurology normal, low back pain, no signs, symptoms of weakness or nothing, fever is there.
Just
But,
also said, Deepak, patient also had a history of ATT. Already he has taken 6 months.
Okay.
Yeah.
Okay. Despite of all these findings, okay?
Yes.
Yes.
Okay. So there is a X-ray shows there is a lytic destruction, end plate sclerosis, end plate changes also there, and MRI also there shows that there is some fluid or edema and some abscess around this space, and along with this, it looks like probably maybe a pyogenic infection. I think I will go for biopsy. Again, repeat biopsy with the help of endoscopy. Transforaminal endoscopy lavage at the same time, lavage and some sample for the biopsy endoscopically.
Okay. Professor Krishna Kumar, can we have your opinion on this?
The evidence of florid inflammation in the setting of diabetes is definitely there. Would like to go for a conclusive biopsy before planning the treatment. First biopsy was not conclusive, but as literature also shows, the yield may be from 45% to 75%. So maybe from a different area, different approach would be the choice in this case. And without a biopsy, going for empirical management, maybe the second biopsy also comes negative, then some kind of empirical, considering it to be a bacterial infection, can be followed. He has already undergone 6 months of ATT. Second would be to investigate in all possible ways for resistant.
The second biopsy would again be a CT guided biopsy, sir, or would you prefer an open route?
No, that is what it depends on what the initial biopsy was. Was it a percutaneous one? Was it a CT guided one? A different technique, different approach, and maybe like Professor Kale said, you can even go for a minimal open approach, choose image guidance, some kind of intraoperative image guidance, and take a very good representative parts, rather than going with a needle, because the yield may not be that. This time it should be a more invasive approach to get a good core biopsy.
Professor Kale, if we can have your views.
This patient is from Yemen.
Okay. Yeah, so you need to know the organism. He has already received ATT for 6 months. It is not working. I don't know, do we have serial MRIs? What happened in the first MRI? What happened after 6 months of ATT? We don't know all that.
Yeah. So, sir, it was I probably not remember sure, but he had not get any kind of benefit from ATT.
Yeah.
Clinical as well as radiological, means it was completely resistance. Dr. Kirti was also following her. So we had to thought for something else rather than TB or something, just to prove the diagnosis and what could be the further plan. So this patient had a severe back pain.
Yeah, so the first step is, of course, biopsy. In case CT guided biopsy or open biopsy, transpedicular biopsy, whatever, whichever way, you need to establish the organism, what is the bacteria, and you should know the resistance of that bacteria to different antibiotics.
Sure.
Without that, it is going to be a blind shot. You can keep trying different antibiotics and you wouldn't know whether it is going to work or not. So you make all attempts to get a biopsy, and then if nothing works, well, you open biopsy. There is no way you can miss it. You go open, give a small incision, open it, and take a biopsy. There is no way you can miss it. Did you get a biopsy ultimately or not?
Yeah, Dr. Kirti?
So we actually did the biopsy.
Yeah.
Because he had a severe pain, we had to fix it also. Dr. Jayesh did a fixation, and the biopsy was actually negative. The disc space biopsy also was negative. The cultures were negative. Even the aerobic cultures were negative. There were no granulomas.
So only one doubtful report of Brucella IgM positive. So that was and that was a microbiological report. IgM Brucella antibody was positive, so we suspect kept as a brucellosis kind of things, but at the end stabilization did relieve the patient. Still,
so this is the diagnosis of exclusion always. Few things which radiologically helps is if we are suspecting TB, generally we have lot of destruction of the vertebra. That's what the literature says, which is not much seen in Brucella. And he had always Brucella comes with an history of some animal contact. He was not like a veterinary practitioner or working in some fields, but he had a history of animal exposure. So with an IgM positivity and completely ruling out any other infective pathology, we decided to treat him empirically for Brucella. So we treated with him doxycycline, rifampicin, and amikacin. Amikacin for 2 weeks and doxycycline and rifampicin for 3 months. And apparently on follow-up from Yemen, he is completely all right. Pain is relieved and nothing, no new symptoms.
Yeah. So one thing you must remember is these things do exist. One is atypical mycobacterium. We must remember, we should not forget about atypical mycobacteria also. Atypical mycobacteria do affect, they are there and they infect the spine. And sometimes you keep thinking about Mycobacterium tuberculosis while it is atypical mycobacteria. And second is Brucella. Of course, Brucella, very good. If you could manage to pinpoint it to Brucella, very good.
Jayesh, what you did? Yes.
I just went for L4 to S1 fixation, and of course that nerve root, decompression and all the things.
But I don't think so there any pressure on
Debridement and no cage or anything, just debridement and L4 5 S1 fixation, open
fixation.
Open fixation, debridement and open fixation.
But the response to treatment is just because of rifampicin and anything, not because of implementation. What do you think?
I think both may work. See, patient had only back pain, so back pain was relieved by stabilization, and probably Dr. Kirti has suggested doubtful brucellus, which probably get respond to doxycycline, but patient get relief in 3 to 4 months, completely relief. He's completely back pain free. So we hope so.
Yeah. So sometimes you have this clinical problem. If the patient is not going to come back to you, you don't know what is going to happen. You don't know, the patient can't afford to take bed rest for 3 months or 6 months.
Yes.
You know that orthosis is not going to work. You have no choice. You go open it up and get a biopsy. And while you're there, you might as well stabilize it. So in a way, your thinking was right.
Yes. Thank you.
Dr. Goel, if I can ask you for your opinion regarding the stabilization in this patient and the need for fixation.
No. You see, I would like to know from Jayesh what kind of fixation he did. Jayesh, can you elaborate on the fixation procedure? How you did?
I did open debridement first, laminectomy, and 4-5 laminectomy. I have checked both bilateral L4 and L5 nerve root, and there were no disc polyps or something. So just a debridement, bell clearance, and then L4 5 S1 pedicle screw fixation, open.
The very fact that your patient has improved, it suggests that you have done a wonderful operation. The proof of the pudding is the taste. Proof of the good operation is the outcome. So I congratulate you on your wonderful outcome. If you had shown the images, it would have been better. And if you had shown me images after 1 or 2 years of surgery, it would have been the ideal. But I agree with what you did. Stabilization, whenever there is pain and there is severe pain, more than nerve root compression, it needs stabilization because it is an unstable phenomenon. The discs are gone, the bodies are here and there. So stabilization is the key in this operation. And then the drugs will be the key.
Yes, absolutely.
And if there is pain is not such a great factor, then the drugs. So my take on this is pain is a deciding issue. If there is a severe pain and the person is unable to handle the pain, stabilization is the answer. If pain is not so severe and there are nothing deficit-wise, then drugs can be tried by biopsy. I think you did a good operation, my dear Jayesh.
Thank you, sir. Thank you. So I think let us finish here. Before we complete, I think 40 to 50 delegates are there. Just I would like to summarize because it was very, very interesting session and interesting discussion. So Deepak said, well, radiological features since 1 to 2 months after clinical response in any kind of infectious spondylitis. And similarly, it has a reverse also, means while your anti-infective drugs react well. So first you will see the clinical response, and after 1 to 2 months, you will see the radiological response. That is very important point you mentioned. Pyogenic is an acute disease. The difference between pyogenic and tubercle disease is cortical differentiation is absent in pyogenic infectious spondylitis. Very well taken point. And pyogenic is acute disease, TB is chronic disease, so symptoms is accordingly. Kale sir mentioned that, Krishna sir mentioned that a CT-guided biopsy is cornerstone of the treatment. For chronic cases, antibiotic should be stopped. This was mentioned by Dr. Kirti. If you are treating the chronic infectious spondylitis, if you have a doubt of repeat CT biopsy, and if you want to correct diagnosis of pyogenic, stop the antibiotic for 2 weeks. Very, very important point. And she mentioned that the most common agent is the Staphylococcus aureus and gram-negative bacilli for infectious spondylitis. Kalishan mentioned that the positive risk factors for the poor prognosis of infectious spondylitis are more than 75 years, epidural abscess, MRSA or MRSE, if patient is immunocompromised, as well as patient is referred from other centers where he, could not treated properly. Very well taken point. If biopsy is failed once, please try a second biopsy before you start the things, either surgery or the antibiotics. Very, very nice point we get it today. Then KK sir also mentioned that, it's very, very important while you explaining the risk of discitis in consent, that incidence of post-op discitis as per as literature is concerned is 0.2% only. For PET-CT, if you have any diagnosis difficulties, then PET-CT is the most sensitive and specific, more than 95% in detection of early infective spondylodiscitis. So very, very important point. He has mentioned that the vancomycin should be the prophylactic antibiotic. And one more important, which I very much like, is remove the instruments only if necessary. So usually we thought that, when you are operating on the pyogenic, you just remove the implants and then you just keep it. Then after patient become okay, then you stabilize again. But he mentioned that remove the instruments only if necessary, no need for extra. So that's all. Thank you very much. Ramani sir, actually, Ramani sir messaged me that he had a fever while he was there. So he wanted to left. Thank you so much, Kale sir, Krishna sir, Deepak, Sukumara sir, Dr. Kirti. Thank you so much for your time. And thank you, my dear friend, Apurva. Thank you, Goel sir, for their presence. Thank you so much.
Thank you, Jayesh.
Thank you.
Thank you. Thank
Good
you,
night.
everybody. Thank you, Jayesh.
Thank you.
Thank you.